The NASGP has always taken a particular interest in the management of mistakes within primary care. Often working in isolation, with little or no support and in environments of enforced underperformance, sessional GPs, and in particular GP locums, can find themselves at the sharp end of system errors and huge variability, with every practice being different to the next by up to 500 different points of variable practice-specific information. We are the veritable canaries in the coal mine. This is Daniel Kahneman, a winner of the Nobel Prize for his work on human rationality, and in 2011 published his highly acclaimed book, Thinking Fast and Slow. It's a distillation of his life's work on behavioural psychology and the cognitive basis for common human errors that arise from heuristics and biases. System 1 thinking is our automatic, fast, stereotypical, intuitive and emotional thinking that we all do almost all the time, even though we are largely unaware of it. It requires little or no energy and enables us to perform simple tasks instantaneously, like completing simple sentences, sums like 2 plus 2, and localising the source of a specific sound. These thoughts are like our own little team of people working in our heads for us 24/7, keeping an eye on everything that's going on, coming in from all senses, leaving our system 2 more energy to perform our more complex tasks. This typical image of an angry face is System 1 thinking in action. It's our jumping to conclusions machine, and through elegant studies Kahneman showed that when most people are shown an image of a face with wide staring eyes and open mouth bearing teeth, most of us automatically conclude that the person is angry, even though there's actually little else to go on. It could be that the person is scared or even laughing. But because there is little other information, the result is a narrative so simple that we don't look for any other evidence and stick with our first impression. System 2 thinking is the much more effortful, slow, logical, calculating and conscious thinking we do, albeit much less often. It points our attention towards something specific, focused or complex. And it only gets involved when we encounter something unexpected that System 1 can't automatically process. It's activated when an event is detected that violates the model of the world that System 1 normally maintains for us. For example, try to solve 23 multiplied by 17. Our muscles tense, our blood pressure rises, our heart rate increases and pupils dilate. It takes strain, effort and vigilance and will eat into our finite energy reserves. With all this effort, our lazier boss mode System 2 relies heavily on our fast System 1 taking the strain. Errors therefore occur when we unconsciously use our faster, easier System 1 in place of our slower System 2. To illustrate how easy it is to confuse these two states, try this. A bat and ball together cost £1.10. The bat costs £1 more than the ball. How much does the ball cost? Using our best guess intuition, most of us will get this wrong. This scenario is perceivably low stakes, with the seemingly obvious answer pretty much given to us in the equation, so much so that System 2 isn't often activated, and we present the wrong answer. The answer is in fact 5 pence, whereas most subjects answer 10 pence. This tendency to substitute simple conclusions that feel right to solve complex problems that otherwise require deeper, nuanced, effortful thinking is a major theme that Kahneman returns to as it crops up in many settings. His work describes many other such errors in thinking, all beautifully evidence-based in clever studies, so much so that this book has been called a masterpiece and a pivotal moment in how we understand ourselves. Cognitive load and its impact on our fixed pool of energy reserves stands out as a particularly pertinent one to us as GPs. Kahneman gives the example of taking a gentle stroll, where we can easily maintain a conversation, but as we begin to climb a hill, as our physical effort increases, we find our train of thought slows as we have to divert more energy to the physical work. Only when we slow will our thinking clear again. This, Kahneman explains, is because our energy for processing cognitive tasks comes from the same pool as emotional and physical ones. Mental energy is not a metaphor. Difficult cognitive reasoning metabolises as much glucose as is required during a fast sprint. We find it patently obvious when our muscles are tired, but much less so when our cognitive energy is depleted. A study of the records kept by Israeli parole judges illustrates this perfectly. Inmates presenting for their parole hearing at the beginning of a session of hearings had a 65% chance of being let off on parole, whereas those presenting when the judge's energy levels were lower, just before a rest break, had around a 0 chance of being let off on parole. Amazingly, until this study, these judges were probably totally unaware of these very human factors that were affecting their performance. And similar findings have been made in other studies. Clinicians performing colonoscopies identify 50% less abnormal polyps in the afternoon, and GPs are 10% more likely to prescribe an antibiotic for a viral condition in the afternoon. Kahneman also writes extensively about the phenomenon of how people are hardwired to jump to conclusions on the basis of limited information and ignore absent evidence, labelling it as the often abbreviated "what you see is all there is." System 1 is constantly seeking patterns and coherence, and when it finds them, it gives us a sense of ease, lightens our mood, and increases our sense of confidence in our judgments, making them more firmly embedded. Our fast System 1 drives to create a coherent and believable story. The less evidence and the more one-sided the information presented, the simpler it is for System 1 to jump to a conclusion. Less is definitely more. On the most fleeting evidence, we can instantaneously infer and invent all sorts of conclusions about the causes of events and the intentions of the protagonists. Kahneman calls these illusions of causality and intention. When shown a large and a small triangle circling around a screen, a consistent finding is that subjects describe the large triangle as either chasing or bullying the smaller triangle, seeing causality and intention as clearly as we see colour. It's an entirely brilliant evolutionary mechanism, helping us rapidly identify and respond to threats by spotting changes in patterns. That sudden swaying movement in the long grass could have been a predator for our evolutionary ancestors. To survive, it's best not to waste any time asking questions, just decide quickly and act. But it can be off-beam in our complex, information-rich world. What you see is all there is a key mechanism in why people can jump to conclusions, assume bad intentions, give in to prejudices or biases, and buy into conspiracy theories. We're all familiar with the phenomenon of, well, I knew that would happen. It's a very applicable and robust cognitive illusion to us in healthcare, where we unknowingly revise our beliefs in light of an outcome. And for GPs it comes at a high price, where we can be unfairly blamed for a decision made that was reasonable given the circumstances at the time. In a study to illustrate this, 2 groups of people were given the real-life scenario of a bridge known to be at risk of blocking, giving rise to the nearby town flooding during a storm. Should the town go to the expense of employing a full-time monitor to detect the blockage? Just under a quarter of the control group said that yes, they should, but the study group were given additional information revealing the actual outcome of the river really having flooded and caused significant damage. Over half of this study group said a monitor should have been employed, even though they had been instructed not to let the outcome affect their judgment. Indeed, in these experiments, the worse the outcome, the greater the tendency to hindsight bias. This is absolutely not about personal weakness or incompetence. It's about powerful evolutionary forces of physiology and psychology. We can't beat it by going on a resilience course and then going straight back to our overloaded jobs. All we can do is learn from the evidence and do our best to implement checks and balances. We must remember and resist the "what you see is all there is" and hindsight bias when we are involved in significant events or in thinking about our colleagues who have been involved in significant events. And as GP locums, be particularly aware too of the adverse effects of cognitive load. Working in often unfamiliar settings, often without adequate inductions into practice-specific processes, we have additional demands on our finite pool of mental resources as our hungrier System 2 is activated for many non-clinical, administrative-type tasks that practice-based GPs will be able to carry out effortlessly using their System 1. So how can we change our culture and systems? Published in 2015, Black Box Thinking by Matthew Syed explains the inextricable connection between failure and success, comparing the psychology, culture and institutional responses to failure and how mistakes are managed in the safety-critical airline and healthcare industries. His book opens with this startling statistic. In 2013, out of 3 billion airline passengers across the globe, 210 people died in air accidents, compared to 400,000 preventable deaths in the US healthcare system alone. This is the equivalent of 2 jumbo jets full of passengers being killed by preventable accidents every day. Black box thinking opens with a harrowing account of a routine operation that provides some clues to the institutional and attitudinal differences between these industries. Mother of 2 Elaine Bromley died after 2 anaesthetists and a surgeon struggled for 20 minutes with tracheal intubation, despite fully trained nurses on standby with a life-saving tracheotomy kit. They later explained to her husband Martin that there'd been a tragic complication, a one-off, and the team had done everything they could. The feeling was that this was an inevitable, unavoidable and rare complication, with bad luck all round. Her husband Martin wasn't angry. He didn't blame the clinical team, but he did want answers. He did not accept that this was a rare and inevitable situation. And that was because, crucially, Martin came from an industry that took a very different approach to accidents. He was a pilot, and as he learned more about what had happened to Elaine, he realised that there were close similarities to previous airline tragedies. The next account is of United Airlines Flight 173 in 1978. The undercarriage safety light failed, so the captain tried everything he could to identify the cause. But despite warnings from the flight engineer, the fuel ran out and the plane crashed, killing 8 people. The response to this incident, compared to that of Elaine Bromley, is striking in itself. There was a statutory immediate investigation into the crash. Historical and real-time data was used, including data from the onboard black box flight recorders, enabling comparison with historical incidents. Everyone involved freely gave cooperation, and any evidence given to the independent inquiry was inadmissible in a court. Within weeks, its findings were disseminated throughout the entire aviation industry, with recommendations for changes to protect aircrews and their passengers using checklists, tools and training simulations. In the time since these changes have been implemented, the spate of crashes that were so typical of the 70s have declined significantly. This is black box thinking in action, and the perfect illustration of an open-loop evolving learning system. Martin Bromley fought hard for a report on the events around his wife's death, and the findings and recommendations were startlingly similar to the Flight UA173 case 30 years earlier. The report, which was titled "So that Others May Learn and Even More May Live," revealed a system that did not allow for the limits of human psychology. The powerful effect of social hierarchy, which had prevented both the flight engineer and nursing staff challenging their colleagues, was clearly evident. Another factor identified was the narrowing of perception and loss of time awareness that affected the flight captain and the anaesthetists. Martin went on to found the Clinical Human Factors Group, a charity dedicated to preventing these types of medical errors happening, with the use of regular time checks during emergencies, clear definitions of team member roles and the breaking down of social hierarchies. A humbling example of an open learning culture in one corner of healthcare, designed by a pilot. So how well has healthcare since progressed towards adopting black box thinking and a growth, open loop, open culture? There's been a lot of rhetoric around developing a no-blame culture, but the culture still remains doggedly stuck with individualising blame for the failures of an overstretched system, with doctors and healthcare staff being held personally responsible, and even criminally responsible for system failings. This attitude to error is best summed up by Professor James Reason of the University of Manchester, and a leading researcher and thinker in human error, who is involved in formulating the Swiss cheese model of error causation and prevention. This is the paradox in a nutshell. Healthcare by its nature is highly error-provoking, yet healthcarers stigmatise fallibility and have had little or no training in error management or detection. The Swiss cheese model represents the layers of error protection, and the holes are the gaps that can allow errors through. It recognises the absolute certainty that human beings will make mistakes, and so seeks to design systems and environments that work around our human nature to reduce the risk of error as far as possible, protecting both the workforce and patients. As we've seen in the case of Flight UA173, the assumption is that if an error occurs, it must be because there is an unacceptable alignment of these holes in the error protection layers which needs identifying and closing. So what stops us applying this approach in healthcare? There exists amongst the public, and even within our profession, a powerful instinct to condemn errors, especially in high-stakes situations where the outcome befalls a patient. As humans, it's psychologically more satisfying to create simple narratives when faced with complexity. And when there's a highly complex series of interacting multi-system failures, our drive is to instead seek a simple solution, preferably embodied in a culprit we can blame and deal with to restore our sense of the world being controllable. This is our deep System 1 need for coherence and stability. The public likes their doctors to be infallible when they need us and things go well. The flip side is that when something does go wrong, we are quickly held accountable for factors not within our direct control. As individuals and as the medical profession, we have to accept that we ourselves may contribute to this illusion of infallibility which can quickly sour to total fallibility. If we fail at something, we are judged by others, but we also judge ourselves. It can feel like a personal failing, not a valuable experience to learn from. It is all entirely subconscious. It's not about consciously covering up errors to avoid external consequences. So adding to the psychological arsenal of what you see is all there is and hindsight bias, another phenomenon talked about by Kahneman is cognitive dissonance. This stems from our instantaneous automatic System 1 thinking and is a powerful mechanism for hiding our failures from ourselves to protect our self-esteem and sense of being competent. It's so subconscious that we often don't realise that we are denying errors. We just don't see the failure in the first place. Take the example of the clinical team in the case of Elaine Bromley, who were not being dishonest when they initially explained to death as a rare and unavoidable complication. Perhaps many of us at first glance would have agreed, but as we've seen, opening up to the idea that this needed investigation revealed areas where system improvements could be made, causing a leap in progress which had protected both patients and the doctors, who are often the double victims in poorly designed systems. So how can we apply this to how we work as GPs? Here's an example of a typical complaint to illustrate these concepts. Dr. L is a locum and has finished a session at a new practice. Immediately after this session, a patient complained to the practice that she'd been abrupt and rude during their consultation. 2 weeks later, another patient seen by Dr. L phones the practice to find out when they can expect to hear about their appointment at the ENT clinic that she'd referred them for. The practice can find no record of that referral. And 3 months later, a 58-year-old lady who had seen Dr. L for hot flushes came in for review. Dr. L had initiated HRT, but had incorrectly prescribed an oestrogen-only preparation. By this stage, the practice are very unimpressed. They discuss it at their practice meeting and decide to inform Dr. L of the errors, and that her performance is below what they will accept in future, so she is no longer going to be booked by them. A fairly typical what you see is all there is approach. So taking all the concepts so far, I'll illustrate the following scenarios, each as a layer in the slice of the Swiss cheese model. Having driven 45 minutes through rush hour traffic, Dr. L arrives promptly 30 minutes before the start of a surgery, but the car park was full and struggled to find a parking space. She presents to reception staff who weren't expecting her, so no room has been allocated, no computer login activated and no smart card details registered. 2 senior practice staff have to set her up to log into the IT system. Dr. L sees that she's being put down to see 18 patients, where it was her understanding that she'd been booked for 12 patients. She sees a patient with pelvic pain who needs a urinary pregnancy test. Having unsuccessfully searched the room, she phones reception on the only internal phone number she's been given and asks if someone can carry out the test so that she can continue seeing patients, as she's already running late. Dr. L is now having to rely on an effortful System 2 thinking for a task that other GPs familiar with the practice will be able to do in automatic System 1. Now over 2 hours into the session, 4 hours since she last ate, Dr. L's System 2 is now tired and very busy. She's just had another complex consultation with a patient who is presented with multiple problems, and so her full attention is on the computer screen as she focuses on safely generating a prescription to initiate a new medication. She's thinking of doses and interactions. The patient continues talking and asking questions, while Dr. L does not register what the patient is saying. It looks to the patient as if Dr. L has been rude and ignored her. The patient is also aggrieved that Dr. L is running late, so decides to immediately complain. Dr. L's 10th patient needs a routine ENT appointment, but she has no information about how the practice manages this sort of referral, so tells the patient she will dictate the referral letter and ask the secretary to contact them if any action is needed. As a safety net, Dr. L remembers to ask the patient to phone the practice in 2 weeks if she's not heard about an appointment. It's 6 hours since Dr. L ate or rested. She has drunk some water from the bottle she carries, but has not been offered any refreshment by the practice. Her surgery is running 40 minutes behind schedule, and she's already late for her next assignment because of the booking error, which led her to having 18 instead of 12 patients. When she meets her final patient, a 48-year-old lady with disabling hot flushes. Like many GPs, it's been a while since Dr. L initiated HRT. She looks at the new layout of the paper BNF and finds it baffling. She's having trouble focusing. Her system 2 is very tired and depleted. She prescribes the incorrect type of HRT. The practice has a digital dictation system, but none of the administrative staff available knows the login for a locum or how to show Dr. L how to use it. So a helpful receptionist gives her an old-fashioned manual dictaphone with a little tape. She dictates the letter and is directed to leave it on the secretary's desk with a loose slip of paper explaining the contents. She leaves the practice to dash off to her next assignment. The secretary comes back from lunch. She's not used these tapes for years and wonders why it's left on her desk. No one knows quite what happened to the hurriedly scribbled note, but it was not clearly connected to the tape and so was overlooked. The secretary assumed it was just some old legacy tape and discarded it. Dr. L is distressed when, 3 months later, she receives a letter from the practice saying that after 3 incidents of concern, they prefer not to work with her again. In the initial response, both Dr. L and the practice have been duped by hindsight bias and what you see is all there is, and they're all the worse off for it. Had a more objective black box approach to these mistakes been taken, many small but significant marginal gains, such as an improved booking process, parking arrangements, induction procedures and much more, could have led to progress and better conditions for all concerned. Or put another way, rather than taking the populist narrative of simply not employing the locum again and singling out an individual for blame, an inquiry led by evidence and data could lead to small changes that make a big difference across the practice. Cases like that of Dr. Hadiza Barwa-garba in 2018 sent a shockwave through the profession when, after initially being suspended by a tribunal, was then actually removed after a High Court appeal by the GMC. The GMC's action very much highlighted the culture of blame within the NHS, completely at odds with encouraging doctors to openly reflect on mistakes in a supportive environment. The then Health Minister Jeremy Hunt's announcement to hobble the GMC's powers to appeal will have given some relief to the profession, although it's going to take a lot more than this to help change a behaviour that, superficially, makes sense and does a good job of removing an immediate problem, but flies in the face of implementing changes to the system that should be in place to protect both staff and patients. What will help us, if years of research by some of the world's top psychologists and economists, and decades of experience from one of the world's largest and ostensibly most dangerous industries has anything to tell us, is that it will be mistakes, and learning from those mistakes, that will ultimately transform the NHS from one of the most lethal industries in the world to what it should be, one of the safest.